I got interrupted finishing this video, but like we said, with the activated PTT, we want to see that the therapeutic level becomes 1.5 to 2.5 times greater than our control value. Control value, of course, we know is the first blood draw, the unmedicated blood draw that shows what you compare everything else to. Sometimes that'll be called the baseline value. In the event that the person is on a continuous maintenance dose of heparin IV, generally you want to draw blood from the opposite arm as your heparin infusion. So say the heparin is infusing into their left arm, you want to make sure that you draw from the right arm so that you don't accidentally get some heparin in that infusion. If they are hanging intermittent IV heparin doses, hanging a small bag, giving you a certain amount and then waiting, you want to check the activated PTT to check the level 30 minutes before the next heparin dose. And in that way they can keep track of it. PT and INR generally are done on an outpatient basis. When somebody first starts Coumadin, they'll draw their PT-INR more frequently, and then it'll gradually space out as the person gets well maintained on Coumadin. And at some point, you'll have people who just need to go in once a month. So what you're looking for is a prothrombin time, PT, 1.5 to 2.5 times normal or control or baseline. And paired with that is an INR of 2 to 3, just a straight number. So say somebody comes in, like I showed on the paper, and they have a baseline PT of 12 minutes, then therapeutic would be 1.5 to 2.5 times 12, which would be 18 to 30 seconds, and your INR is going to be somewhere between 2 and 3. So if the person is, 2.5, they would consider that to be a therapeutic dose of Coumadin and would probably leave them on that until their next PT-INR check. Of course, when it comes to giving these meds, as always, we're going to stick with the nursing process. I am so sorry. This is not wanting to stay where I have it propped. But things that we need to know about anticoagulants, of course, you do your assessment. Your diagnosis, a nursing diagnosis, is going to be focused on areas of tissue perfusion, education, and safety. The way to evaluate is to look at the proper lab values. We want to tell somebody that after they stop anticoagulants, if they're not on anticoagulants permanently, they need to be careful. Many times the anticoagulant will remain on board for a week or so, and so they need to be pretty careful about activities that could increase their risk for bleeding. So usually they'll give them 2 weeks. For patient and family teaching, once again, early sign of overdose or internal bleeding is bleeding gums. They should watch for that. They want to avoid contact sports. If they've just been on a month-long course of low molecular weight heparin and they're able to stop, they don't want to start, touch football or, some sort of a contact sport while that anticoagulant may still be in their bloodstream. And if they're on chronic anticoagulant use, they just pretty much need to be careful all the way around. If they hit their head, they can get a brain bleed that doesn't stop easily, and they can get hematomas. For shaving, somebody on anticoagulant should use an electric razor just to cut down on those nicks. Of course, nobody's going to bleed to death from a little nick, but if they cut themselves shaving or they get a scrape and they're still oozing blood after 10 minutes, that can be a sign that their PT-INR is too high. It's no longer therapeutic. It's now indicating too much Coumadin in their system, and they need to call the MD for a PT-INR and an adjustment of their medication. Heparin, whether it's heparin sodium or low molecular weight heparin, is a pinch drug. It is dangerous, and according to JCAHO, heparin doses always have to be checked with another nurse before administering. So you draw up your heparin, or you get out your pre-filled syringe of Lovenox and you determine how much you need to give that patient, and then you run it by another nurse who is supposed to sign after you.